Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Ashinsky of RWJBarnabas Health Medical Group. Heart disease is the leading cause of death in the United States in both men and in women. As we celebrate American Heart Month, our show today will focus on steps you can take to promote your heart health and reduce your risk factors and the services available to help you diagnose and treat heart disease. We are pleased to have three cardiac experts from RWJBarnabas Health join us today. Dr. Justin Fox, a board-certified cardiologist and interventional cardiologist at Robert Wood Johnson University Hospital, Hamilton. Dr. Leonard Lee, a cardiac valve surgeon who is Chief of Surgical Services at Robert Wood Johnson University Hospital in New Brunswick. And Dr. Rachana Kulkarni, a board-certified cardiologist with Medicor, an affiliated medical practice of RWJBarnabas Health, who is also on staff at Robert Wood Johnson University Hospital, Somerset. Dr. Kulkarni is currently the Director of Community Cardiology and Preventative Health for RWJBarnabas Health's Southern Region and a physician leader with RWJBarnabas Health Women's Heart Health Collaborative. Welcome to the show. Thank you all for being here on the show. First, I'd like the studio audience to learn a little bit about all of you. So I'm going to start with females first. Dr. Kulkarni, tell us a little bit about yourself, your background, and any special interests you have in cardiology.
Sure. Thank you, Doug. My name is Rachana Kulkarni, and I'm a cardiologist in the health system at Robert Wood Johnson, Somerset, and New Brunswick. I have been in practice with Medicor Cardiology. This is my 26th year in practice. And my area of interest and passion are heart disease prevention and raising awareness for heart disease in women. So those are my two areas of interest. Thank you so much for having me here.
Thank you. Dr. Lee, a little bit about your background and your any special interests.
Good morning, and thank you. I am Leonard Lee. I'm the professor and chairman of the Department of Surgery at Rutgers Robert Wood Johnson Medical School. I'm also chief of surgical services at Robert Wood Johnson University Hospital. I'm also a practicing cardiac surgeon, and my areas of interest are primarily seated in valvular heart disease, primarily aortic valve and mitral valve repair, complex repair, as well as thoracic aortic aneurysm disease, in addition to all adult cardiac surgery.
Thank you. And Dr. Fox, a little bit about yourself.
Yeah, thank you. And thank you for having me on this on the program. I am a interventional cardiologist at Robert Wood Johnson University Hospital in Hamilton, and I'm part of a practice group called Hamilton Cardiology Associates. I've been in practice here for 12 years. My areas of clinical interest include interventional cardiology and procedures we do in the cardiac cath lab, angioplasty and stenting, and I pride myself on trying to perform the most minimally invasive versions of that. But I also have a strong interest in prevention and have a busy office-based practice. So my area of interest really does run the gamut from preventive cardiology all the way to some of the more advanced treatments that we can offer.
Thank you each one of you for everything that you do. Now, I'm a primary care doctor. I'm an internist, been in practice 35 years in the Warren area. And being an internist, I see a lot of older patients. Therefore, one of the important questions that I ask people, and one of the things that I have to look at is heart disease. So can each one of you talk a little bit about heart disease prevention, risk factors, so the studio audience understands what we're all looking at?
Sure. So heart disease is the number one killer in the United States because it affects a broad segment of population. 1 in 3 deaths in the United States are because of heart disease. And a lot of heart disease is preventable if we identify and address risk factors. And the risk factors can be broadly categorized into modifiable and non-modifiable. And non-modifiable risk factors are our age, sex, ethnicity, the genetic package we are born with. And modifiable risk factors are where, as a medical society, as community, we can put a lot of emphasis in. And those are high blood pressure, diabetes, high cholesterol, smoking, physical activity. So these are risk factors that if we identify and address, a lot of heart disease is preventable. And it starts with you, Dr. Ashinsky, when we don't know if we have high blood pressure unless we know our numbers. And that's why seeing you and getting their numbers known is very, very important.
Dr. Lee, anything to add?
Well, by the time patients see me, it's a little too late to be talking about prevention. But I can talk about what happens after heart surgery. And you had spoken about the aging population. The aging, every 25 years thereabouts, the aging population doubles. So those patients over the age of 80 across the world doubles every 25 years. And we all know that we're dealing with an older and sicker patient population than we had in the past. When I first went into practice roughly 22 years ago, the average age of the patients that we operated on was somewhere around 70. Now it's somewhere in the range of 78, and we don't see that number coming down anytime in the near future. So what we do tell our patients is once we have intervened, that all those modifiable risk factors that Dr. Kulkarni spoke about are critically important to prevent them from having a secondary occurrence of their heart disease. So whatever you can control, you have to control, and that's what we tell our patients.
And Dr. Fox, anything else to add?
Yeah. No, I think both Dr. Lee and Dr. Kulkarni said things beautifully, but I'll point out that as an interventional cardiologist, there are times that at 2 or 3 o'clock in the morning, I'm meeting a patient for the first time, and it's at that hour because they're having a heart attack, the big one, a medical emergency. And for a lot of those patients, that's their first sense that they had any heart disease, their first inkling that there was a problem. And maybe they saw other doctors, maybe they didn't get any medical care, but the rate of people having heart attacks, and even those we don't meet, the rate of those patients or people who pass away suddenly from heart disease who never knew they had a problem remains way too high. So the best thing I could say is that, yes, some of our risk factors are modifiable, some are not, some are treatable with medication, many of them are. And I would encourage anyone out there in the community who's really an adult to have a proper medical evaluation and have their blood pressure and cholesterol checked. And then sometimes a deeper dive can be taken to look more carefully for heart disease, because a lot of the scary events that I see happening in the middle of the night to patients are preventable with just that general preventive approach.
So when we talk about heart disease, everyone's concerned, I have heart disease, I should be going to New York City. No, they shouldn't. What they need to do is they need to understand that at Robert Wood Johnson, RWJBarnabas Health, we have a full gambit, full line of everything from the primary care doctor, the cardiologist, to the full-blown, we can do the surgery at the University Hospital. So let's talk about the different cardiac services that are available both at Robert Wood Johnson University Hospital, Somerset, Robert Johnson University Hospital, Hamilton, versus a tertiary care center such as Robert Wood Johnson University Hospital, New Brunswick. So, Dr. Kulkarni, tell us what's going on at Somerset.
Sure. Somerset has a wide breadth of all the cardiac services. It's one of the busiest community hospital as far as cardiology services are concerned. So we provide full services. So non-invasive testing, including echocardiogram stress test, nuclear stress test, all of that is available. Should one or someone's loved one presents to our hospital with a heart attack or any cardiac emergencies, we have a very busy cardiac cath lab that can take care of any intervention or cardiac catheterization, any angioplasties. It's one of the busiest cath lab for coronary interventions. In addition, we can also do pacemakers, any tilt table test, transesophageal echocardiogram. So the whole entire breadth of cardiology procedures and services are available at Somerset.
And Dr. Fox, tell us about what goes on at Hamilton.
Yeah, well, Robert Wood Johnson Hamilton is a very busy hospital as well. And you talk about that difference between the University Hospital and I guess what you would call a community hospital, which is like Robert Wood Johnson Hamilton. We do serve a very large area. We serve all of Mercer County, as well as taking significant patient influx from Middlesex and Ocean and Burlington counties. We have a very large catchment area, and we are a very busy hospital. My practice manages the cardiac services at Robert Wood Johnson Hamilton. We have a busy outpatient practice, and we do provide all services in-house with the exception of cardiac surgery, which Dr. Lee will talk about at the University Hospital in New Brunswick. So in our hospital, we also have a very busy cath lab. One thing that viewers of this program may or may not be up to date on is that the law in New Jersey changed within the last few years, and a community hospital like Hamilton or Somerset is now a site where we as cardiologists can perform routine angioplasty and stent procedures. So prior to that, those procedures in New Jersey could largely only be done at hospitals with cardiac surgeons on site. But multiple studies have been done in this field over the past 10, 20 years showing that cardiac cath procedures with angioplasty and stenting can be safely done at a hospital like Hamilton or Somerset. And in fact, they now are being done because since early 2022, we've been doing those procedures at Robert Wood Johnson Hamilton, and it's gone exceedingly well. We're very busy. We're getting great patient outcomes. Patients are having a very positive experience. We have set up a throughput of patients through a dedicated interventional suite where they have their pre and post-procedure care. We hired extremely qualified and experienced nurses and technicians for our cardiac cath lab. And the cardiologists, which are myself and several of my colleagues, are able to do a wide array of cardiac interventional procedures in the cath lab with a great rate of patient satisfaction and procedural success.
And Dr. Lee, tell us about the Tertiary Hospital in New Brunswick.
So New Brunswick, we are the academic medical center for the entire health system. We have a medical school here, Rutgers Robert Wood Johnson Medical School. We also have the academic, our hospital partner, Robert Wood Johnson University Hospital, which is a large tertiary care hospital, as you had stated. And an important point to all of this is that in places like Somerset and Hamilton, the care that is delivered is outstanding. It's very, very good, very high level care that's delivered in the patient's backyard. So this should be the first resource for the patients to get their care. Also, there's knowledge of the patient is really important in terms of how you care for these patients. Dr. Kulkarni, Dr. Fox follow these patients, and so when it comes time to treat them, they know everything about them before any escalation of care. Now, when the care that is required needs to be escalated because it is now no longer able to be performed at the local setting, that's when we bring the patient to Robert Wood Johnson University Hospital. At Robert Wood in New Brunswick, we have a very large cardiac surgery program. We're one of the largest in the Northeast. We do somewhere in the neighborhood of 1,700 heart surgeries per year. We're also one of the largest minimally invasive valve centers, where we do valve surgery through a 2-inch incision on the right chest, and the patients go home in 2 days. We also have a very, very large transcatheter program. This is a procedure called TAVR, transcatheter aortic valve replacement, where we are literally able to replace the valve through the leg. And Dr. Fox is one of our collaborators in terms of these procedures. So we're able to offer the full spectrum of care for these patients, not only on an elective basis, but on an urgent and emergent basis as well. We have a cardiac transplant program. We have a mechanical circulatory support program, which means these are all devices that can be implanted into the failing heart to buy time, get them over the hump to recovery, or bridge them to a further intervention in the future. We also have an ECMO program, which is allowing to care for the sickest of the sick, for patients whose lungs and hearts have failed. And so this is what we do when the care needs to be escalated.
If I can add here, it is so nice to have this world-class care team for tertiary care in cardiology right in New Brunswick under Dr. Lee's leadership, because it's so important. As he said, patients know us and we have followed them longitudinally for years, but it gives us so much comfort as community cardiologists to know that an excellent care team is there in New Brunswick whenever escalation of care is needed, and we work very good as a team. I cannot say more. I cannot say how great Dr. Lee's team is and how there is constant communication. The beauty is that Dr. Lee's team communicates with us, and we can take over patient care in a seamless fashion when the patient recovers from the tertiary care procedures that they need. So it's continuum of care, which is very important.
Yeah, and I was going to point out that our hospital, approximately 35-minute drive from the hospital in New Brunswick, and myself and several of my colleagues are also on the medical staff and do procedures in New Brunswick. So we're able to do, as you said, 90% of what our patients need in Hamilton, but there are some cardiac procedures that we cannot provide in that size hospital. One of them is certainly cardiac surgery, and we have a great working relationship with Dr. Lee and several of his colleagues, and have had outstanding results for our patients when they're cared for by Dr. Lee's team of surgeons. There are some interventional cardiac procedures that we cannot do without surgical backup, and those include the TAVR procedure, and we've had a great collaboration. Myself, two of my colleagues have collaborated very nicely with Dr. Mark Russo, who's one of Dr. Lee's colleagues, to do TAVR procedures on our patients, and have had outstanding results over the past several years, collaborating with Dr. Russo, and we do those procedures together. Those procedures are done by cardiologist and cardiac surgeon working together, and it's been a really fruitful collaboration. There are some cardiac cath lab procedures that we cannot do at our smaller hospital. It's a minority, but there are certain procedures that require what's called rotational atherectomy, which is like a little roto-rooter device to break up plaque. And there are some procedures that require a device called Impella, which is a temporary heart pump that we put through the femoral artery in the leg. And I've had really positive and excellent experiences with patients where we identify their problem in the cath lab in Hamilton, and then can arrange for either a transfer or an outpatient scheduling of their procedure in New Brunswick to do the more complex procedure in New Brunswick. And this has all gone very well, and it's been an outstanding way to bring these more advanced procedures into the realm of possibility for patients that are closer to our hospital.
Just like Dr. Fox said, our team also has privileges in New Brunswick, and my colleague, Dr. Danielle Fung, works very well with Dr. Russo to do the TAVR procedures. And when the patients are there, just like Dr. Fox said, our team is working with Dr. Lee's team to see them, so they're not left without the doctors that they know.
Now, Dr. Fox, tell us a little bit about the heart transplant program at the University Hospital.
So we have a transplant program here. We do somewhere in the neighborhood of 15 to 20 heart transplants per year. Some of these patients are what we refer to as elective, meaning they're at home with failing hearts on a list awaiting a heart to become available. The others are more acutely ill and are in hospital on a device supporting their heart while waiting for a heart to become available. It's an active program. It's all incorporated in with what we call our ventricular assist device program, or VAD, which is another device that supports the heart, a little bit more on an outpatient versus inpatient basis. The other thing I want to dispel is the myth of New York City. New York City is a location. It has nothing to do with quality of healthcare that's delivered. There's nothing magical about New York. New York doesn't have anything we don't have. They don't provide better care than we do, and many times it's actually worse care. A lot of the city hospitals can be mired with bureaucracy and politics and difficulties in navigating patients. Oftentimes, the efficiencies of places like Somerset and Hamilton cannot be replicated in these bigger hospitals. So again, to everyone's point on this, 90% of the care that's delivered should be delivered at the local place.
Now, tell us also about the whole Tava program. Everyone has been hearing about it. It's on the news. You see it on some of the doctor shows on TV. Tell us about the Tava program at University Hospital.
So TAVR is a part of this greater, larger entity called structural heart. And structural heart is something that surgeons have dealt with our entire career. But with the advent of new technology, we're able to deliver these devices in a less invasive way. Not everything is known about TAVR yet. It's been FDA approved since 2011. It is a procedure that's done through the leg where we can deliver a valve under X-ray guidance into the heart. We can displace the patient's own sick valve out to the side and put a new valve within it. It works pretty well. It's not perfect, but definitely for the patients who need it, it's actually the best thing for them. As time goes on, more and more data will arise, and I'm sure the procedure will evolve and more technology will become available to impart onto our patients. Also, there's devices that treat mitral valve disease as well, one of which is mitral clip. There's transcatheter mitral valve replacement. So there's a whole spectrum of new procedures that we're able to perform on our patients for the benefit of their hearts in the end.
And I'm sure you're also doing a lot of clinical research there also.
Yeah, we have a fairly active research program. It's all part of being the academic medical center. I have a basic science lab in addition to performing clinical research. We have clinical trials here, residents, fellows, trainees, medical students, the whole gamut.
I wanted to point out that TAVR has really been one of the biggest advances in our care of patients in the last 15, 20 years in cardiology. And the reason for that is that it treats the condition of aortic stenosis. It's where the aortic valve, which regulates how blood passes out of the heart, that valve can become calcified with a lot of calcium deposits and narrowed, particularly in the elderly population. A lot of the patients receiving this procedure are in their 70s, 80s, or even 90s. And historically, the only treatment for those patients was open heart surgery, which would be an incision in the chest and stopping the heart, putting them on the heart-lung bypass machine, and surgically replacing the valve. Many of those patients are older and frailer, and that would come with increased risk. So the TAVR procedure, as Dr. Lee said, is done through the blood vessels. It does not require an incision on the body in the vast majority of cases. And even in the 12 years that it's been out, the procedure has become less and less invasive. The equipment has become smaller. A lot of these patients go home the next day. A lot of them just have a 2-centimeter little scab in their groin from the access site, but no other marks on their body. Even in the most elderly and fragile patients, certainly we treat them with care and have to be very cautious in how we decide on their treatment plan. But I've seen some very fragile, sick patients who really had no surgical option come through a TAVR procedure with flying colors, and it can dramatically change both the quality of their life, because the diseased valve can make them very short of breath and have other cardiac symptoms. And also, it's known from the clinical trials, and we see it in front of our eyes, it prolongs their lives. It improves both quality and duration of their lifespan. And it's a patient population that had no treatment options 15 years ago.
Yep, and I would add to that having a robust TAVR program has opened up so many options now for so many people that did not have that option before. And it can be done by your own cardiologists with a surgical backup, and Dr. Russo does a great job with TAVR and other structural heart programs. So it's a great option now that's available for a lot of patients that did not have that option before.
So now they've gone through the procedure, or they've had their, they've getting close to discharge from the hospital. Cardiac rehab, important, yes?
Very important. Very, very important. And I would like to add that it's quite underutilized. And as you know, Dr. Shinsky, that cardiac rehab is a program. It's the whole intent of us treating a patient, if it is for heart failure, heart attacks, or bypasses or any other procedures, is to get them back and better than when this whole process started. And cardiac rehab is an integral part of it. We get patients back to what they aspire to with the help of physical therapists and nurses and a monitored, structured exercise program. And it's very important, and it's being given at all the hospital sites, and it should be taken advantage of.
Yeah, for those who don't know, who have not gone through the experience, what it is it's an outpatient exercise program, and it typically runs for about 3-month duration for a particular patient. And they may go usually 3 times a week, although that schedule can be adjusted based on the patient's need. And really, based on the way it's indicated, based on the way it's covered by insurances, any patient who has almost any cardiac procedure is eligible for that, whether it be a stent, open heart surgery, TAVR, or any other cardiac procedure. And it's also indicated for other diagnoses, such as angina, if someone has chronic chest pain from blockage, even if it can't be fixed. It's indicated for congestive heart failure, probably underutilized in that population particularly. And I'm a big advocate for sending my patients with CHF, congestive heart failure, for cardiac rehab if they're interested in doing it, because the cardiac rehab, you really see a difference. The patients come back and they have more confidence, they have more stamina, and they really end up connecting with the population, with each other in the cardiac rehab as well. It's almost like a little family between our exercise technologists, the nurses, and the patients themselves, and it's a very supportive environment.
And a lot of times patients don't realize that after they go through these procedures, a heart attack or bypass, they are not sure as to, can I exercise? Should I exercise? How much can I do? And in the cardiac rehab, it's a structured and monitored exercise program that rebuilds the confidence. And in addition, what Dr. Fox said, it's almost serves as a support group, along with increasing functional capacity. It's emotional support as well.
Well, all three of you, thank you very much for being here. Before we close the show, I want to give each one of you a minute to just tell the audience one last thing to think about.
Sure. Heart disease affects a lot of us, our families, our communities, and it's largely preventable. So I would suggest know your risk factors, know your numbers, see your primary care physician, and then with their help, chart a course of maintaining heart health. And we will be very happy to take care of you and whatever your cardiac needs are. But first, know your risk factors, identify them, and work with your primary care team and the cardiology team to address them and modify them so you can live many, many years of heart healthy life.
Yeah, I think that was beautifully said. And I'll say one of the things I love about being a cardiologist is our ability to help patients, help people across the whole spectrum of heart disease illness. And that includes the beginnings of it with prevention, which I'm very passionate about, all the way to some of those more advanced treatments, whether it's emergency care for a heart attack, doing a valve replacement, and all of those things. And we have so much to offer our patients and so much that we can do to improve their quality of life, as well as prevent bad health outcomes. And it really all it takes is to be on top of your health, see your primary care doctor, see a cardiologist if it's appropriate, and we're there for you. We have what it takes to help people through these situations.
So I just want to echo everything that everybody else said. I'm a surgeon. We love to operate, but we would rather have a healthy population. So be responsible, take control of your own health. Don't be passive. Look for the care.
Thank you all for being here.
Thank you.
Thank you.
Thank you.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call 888-724-7123. For more information about cardiovascular services at RWJBarnabas Health, please visit rwjbh.org/heart.